All right, we're going to go ahead and get started. I want to thank you all for listening. My name is Devin Archer. I'm a fourth-year pharmacy student at Auburn Harrison School of Pharmacy. I'll be talking a little bit today about apnea of prematurity. So first off, we will just define apnea in general, as well as give a definition for apnea of prematurity. So apnea in general usually includes the pause or stopping of breathing for about 5 to 10 seconds. But based on pediatric guidelines for apnea of prematurity, it's defined by the stopping of breathing for at least 20 seconds or a shorter episode of apnea, which includes bradycardia, cyanosis, or pallor. The cyanosis is going to be more of like a blue discoloration of the skin due to just a lack of oxygenation in the blood. And pallor is going to be more like a paleness or a loss of color to the skin. Looking at risk factors for this medical condition, as the name states, it's apnea of prematurity. So one of the biggest risk factors is going to be young gestational age. So term babies are usually around 37 weeks. So most babies with risk of 36 weeks gestational age or younger are at an increased risk for developing apnea of prematurity, as well as extremely low birth weight, which is common in these premature babies as well. It's usually specified around less than 1,000 grams is what we classify as extremely low birth weight. And just as a fact, 80% of neonates with low body weight under 1 kilo often experience apnea. So in general, there's 3 different classifications for apnea of prematurity. You have obstructive, central, and mixed. And I'll go through the 3 of these on the next slide. So for central apnea of prematurity, this is going to be related more so to brainstem maturity. It involves decreased stimulation from the central nervous system, hence the classification for the central, and it's decreased stimulation for the respiratory musculature. In general, this is going to be a deficiency in both the airflow and also just the breathing mechanics involved. And like I said previously, it's related to the brain maturity. It's based on delayed neuronal conduction. So the more immature the brainstem is, the more likely you're likely to have central apnea. As far as obstructive apnea of prematurity, this also involves decrease in airflow with functioning breathing mechanics. This can occur in the larynx as well as the larynx plus the pharynx, and it can lead to pharyngeal collapse. And it ends up going to pharyngeal collapse, usually caused by just like upper airway muscle inability or just like negative pressures produced during inhalation. And then mixed is going to be the most common classification of apnea of prematurity. It's going to be a combination of both the central and the obstructive classifications. You'll see properties of both or characteristics of both in this. And this is the most common, and more than 50% of patients with apnea of prematurity have the classification of mixed. So it's just some other considerations in regards to classifying and just diagnosing this medical condition. Usually symptoms present within the first 2 days of life. Less than 35 weeks gestational age should be monitored for at least a week, first week of life, just to see if any symptoms were to present. And then apnea episodes can or cannot be present whenever you're on mechanical support. So it's also just important to continue to monitor that as well, especially it can occur while like weaning off or discontinuing the mechanical support. And then it's also just important to consider other secondary causes that may experience with like delayed apnea. And delayed apnea can occur a week after life or even later, or a week after treating an apnea episode. So in general, for diagnosing, you diagnose by excluding other factors out. There are many causes of apnea in neonates, which I have a full list on the next slide, but you want to rule out the other diagnosis of any other conditions or factors that are causing apnea. You can do this by using a physical assessment. Specifically, you want to look at temperature as well as respiratory, just a full respiratory evaluation. Looking into labs, you want to get a full CBC, including white blood cell count with differentials, as well as red blood cells and platelets. You want to do this to help rule out any signs of an infection or any sort of anemia. Also, you would like to get a BMP as well, just to look at your electrolytes and your glucose to just rule out any metabolic disorders as well. And then lastly, you just want to look at the mother's history as well as the patient's history involving, was there any sort of medication exposure or any sort of risk for infection, as well as just looking at your oxygenation status as well with your arterial blood gases. So like I said, there's many different causes or potential causes for apnea, and this is just an extensive list here for you. It includes some of the things we did previously talk about, like anemia. So that's why you'd like your CBC. You can have GERD, infection as well goes with the CBC. Neonatal medications such as anesthesia or opioids that maybe the mother received. Seizure activity, hypoxemia, intracranial hemorrhages, metabolic disorders. So looking at your electrolytes and your blood sugars, perinatal asphyxia, as well as temperature instability. Overall, your goals of treatment for this, you're wanting to limit, but ultimately overall eliminating these apnea episodes, especially the ones or any episodes that result in that low heart rate or the cyanosis that you're going to experience. And you're going to want to use both pharmacological and non-pharm treatments and in order to help treat this to prevent short-term and long-term complications. So first, I'll briefly go over the non-pharm treatment options. They're all listed here, starting with manual stimulation, which is the most common, and then there's other ones such as airway patency, maintenance, red blood cell transfusion, supplemental oxygen therapy, as well as respiratory support. So first, we'll talk about manual stimulation. Like I previously mentioned, this is the first line non-pharm therapy that you use. And this just typically involves just stimulation by just rubbing the chest and back extremities just to help promote spontaneous breathing. Then you have airway patency maintenance, and this is primarily based on the positioning and based off just the instrumentation that you use. Neck positioning is important for this because it can lead to a potential airway obstruction. So it's important to maintain that, as well as it's important to just limit the extension of the neck to decrease any sort of apnea risk due to a potential obstruction. And NG tubes can impair this airflow, so it's important to watch out for that as well. Three other ones here listed. Red blood cell transfusion overall just help with hypoxemia as well, just delivering oxygen throughout the body. With transfusions, you have an increased risk for like retinopathy of prematurity or necrotizing enterocolitis or NEC. So it's something to monitor if you were to do a transfusion. For supplemental oxygen therapy, this also helps reduce hypoxemia by increasing the oxygen saturation. And like the red blood cell transfusions here, you also have an increased risk for that retinopathy and NEC as well. And lastly, respiratory support, which is commonly used as well, using CPAP, which continuous positive airway pressure is used to help with more of the obstructive components. And this just helps like increase the functional residual capacity and prolong the time for apnea to desat, as well as timing for bradycardia. Continued apnea following CPAP and pharmacological treatment may require an endotracheal intubation. So next we'll transition into the pharmacological treatment options. The primary drug class that we use here are the methylxanthines. These include aminophylline, caffeine, and theophylline. For this presentation, I'm mainly going to focus on caffeine as well as theophylline. In general, the methylxanthine mechanism of action is not completely well understood. However, it does have properties that inhibits the phosphodiesterase as well as adenosine, which helps with smooth muscle relaxation in the lungs. And adenosine also helps with decreased respiratory drive as well. Since I won't be talking about aminophylline in this presentation, I just wanted to make a few comments on it. Just in general, it's the prodrug for theophylline, as well as it's usually dosed 3 times a day, and it's relatively expensive, so we use the other two as alternatives. So first, I'll talk about caffeine, and this is typically your drug of choice for treating apnea of prematurity. It's a drug of choice typically because it's once daily dosing. It has a wider therapeutic index than theophylline, as well as it has more favorable ADR profile. So it can be based on as the salt or base, and it can be administered intravenously or by mouth. Typically, you start with a loading dose of 20 to 40 mg per kg. And then you have a maintenance dose of 5 to 10 mg per kg as well. And this is daily dosing, like I previously mentioned. The desired concentration here therapeutically is 8 to 20 milligrams per liter. And toxicity levels go up to about 50 mg per liter. And so monitoring, you're not going to really want to get any plasma concentrations for efficacy or anything like that, unless for whatever reason, if there's any suspected toxicity or if apnea is not resolving. Here, you're monitoring parameters. You're looking more so at your heart rate, your cardiac rhythm, your respiratory rate, as well as your oxygen saturation. And the ADR profile, this was another reason why this is a drug of choice for apnea typically. It has less GI side effects as well as less incidences of tachycardia observed with a lower maintenance dose of the 5 mg per kg versus 10 mg per kg when looking at maintenance doses for capsid. Theophylline is the alternative medication as well that you can use for apnea of prematurity. It's available orally as well as intravenously also. The oral dosing is listed here at 80 mg per 15 mil IR by mouth. It's a solution. You do a loading dose of 5 to 6 mg per kg for one dose, and you have a maintenance dose of 2 to 6 mg per kg per day divided into 2 to 3 doses. And then the IV formulation is 0.8 mg per milliliter and 1.6 mg per milliliter concentrations. The desired concentration here for efficacy purposes is 5 to 12 mg per liter. And note that the toxicity of 15 mg per liter is where toxicity starts. So you have more of a narrow therapeutic index here, and you have to look out for potential risks for toxicity with theophylline. Monitoring parameters for this alternate compared to capsid, you do want to monitor those plasma concentration levels. You always want to monitor those after initiating therapy, as well as when you make any dose changes to theophylline, or if you add any sort of CYP inhibitor or inducer, and just throughout maintenance therapy as well. Like capsid, you also want to look at your heart rate, cardiac rhythm, respiratory rate, as well as your oxygen saturation. And with theophylline, you are worried about some potential drug interactions. Typically, any medications that have CYP1A2 medications, and also phenobarbital, which also is sometimes used in neonates for seizure activities. And the ADR profiles, you want to look out for signs and symptoms of any risk of toxicity. And with theophylline, you can have long-term effects such as increased risk for cerebral palsy. And this risk is often increased for babies that are less than 1.5 kg at birth. I listed here signs and symptoms of potential toxicity for theophylline just because you have that very narrow therapeutic index that you want to look out for at 15. So some symptoms that you can experience for potential theophylline toxicity include irritability, feeding intolerance, cardiac arrhythmias, GERD, tachypnea, seizures, as well as increased metabolic rates and mild diuresis. Overall duration of treatment, typically this apnea of prematurity typically resolves between 36 and 40 weeks post-conceptual age. Some neonates do require longer treatment times. More likely patients that were born between 24 and 28 weeks typically maybe sometimes have a little bit longer treatment duration. Typically here, we try to discontinue caps at around 34 weeks as long as the patient's not experiencing any apnea symptoms. Following discontinuation of therapy, it's important to continue to follow up with the patient between 5 to 7 days after stopping therapy, just due to the extensive half-life of these medications that are experienced in preterm neonates. And these are my references, and thank you guys for listening.